but let's support the NHIS to do this. NHIA, as we all know, has its own set of constraints. It's a scheme that was funded 20 years ago. This year, we're celebrating 20 years of the scheme. But what is critical is that the funding to the scheme has remained almost the same in terms of our premium collection. One of the co-panelists also mentioned, as we speak today, the informal sector, these are people who are not on slate, pay at most 30 cedis for a whole year on being on the National Health Insurance Scheme. And if you're a slate contributor, you're paying something around 6 or 7 cedis as processing fee for a whole year. About 70% of the members on the scheme do not pay any form of premium. How can this scheme stand on its feet and shoulder all these disease conditions that is being thrown at NHIS on a continuous basis? As we speak, there's call for inclusion of prostate cancer, there's call for mental health, there's call for dialysis. All the calls keep coming, but the conversation stops at how NHIA will fund all of this. So the conversation must continue. The biggest source of revenue for NHIA is the levies, which contributes about, this NHIL levies contributes about almost 93%. The levies come in, and as again, co-panelists have rightly said, doesn't come straight to the NHIA. It goes into a central fund for reasons. Of course, the fund itself is also capped. So even monies that is allocated to the scheme is not received at the end of the year in totality. That gap, of course, we know goes to fund other emergencies and so on and so forth. But we must have that conversation to an extent where what is due NHIA perhaps should come to NHIS. So NHIA will be liquid enough and to be able to take on everything that is being thrown at it. In the landscape of our health architecture, the providers are providing services. Ordinarily, NHIS should be the payer and should be able to pay. But from the onset, the framers of the law knew why certain conditions were excluded from the scheme. It's been 20 years on. Hence, we have to get back to the basics and to see whether it's now time for us to include certain conditions which today are becoming an issue. Lifestyle diseases, as has been said. At the center of all this conversation is finding sustainable funding mechanisms to pay for dialysis, to pay for everything else. This conversation must not stop. And I'll say it should continue for us to have a common ground where the NHIS is liquid, there's inflows, and the inflows is able to take on new disease conditions as we go forward.
Okay,